This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.
Hello, my name is Dr. Rob Page, and thank you for joining us here for another episode of Doc Talks. Doc Talks is a podcast that is produced by the Knoxville Academy of Medicine and features its physician members providing information to patients about topics of interest, be they current problems or common problems or even some uncommon problems, to give patients more information on how they can address these issues. And I'm very fortunate to have with me today Dr. Daniel Snyder. Dr. Snyder is a pathologist, but he's a specific type of pathologist. He's a cytopathologist, and he's here to talk to us today about Knoxville FNA Clinic.
Yeah, thank you for having me.
Now, very glad to have you, Daniel. So, tell us exactly what Knoxville FNA Clinic is.
So, Knoxville FNA Clinic is a freestanding clinic. It's not located within a hospital. And I, as a pathologist, operate the clinic, and it's a little bit different than what most patients usually would think of when they think of a pathologist. I actually see patients in consultation in my clinic. Usually patients are patients that have been referred for a suspicious mass or lump that they've either felt themselves or that a provider has identified on their body that needs a biopsy. And I actually see the patients, examine the patients, and using ultrasound guidance, I perform a biopsy that I also interpret in my clinic.
So, FNA, what does FNA stand for, and what would it entail?
So, FNA stands for fine needle aspiration, and it's a type of biopsy that's extremely minimally invasive. It uses a very thin needle to guide the needle into a mass to collect a sample, to extract some tissue that I can put on a slide and look at under a microscope.
So it's a very small way to sample tissue, as opposed to what other techniques are typically used that would be more invasive or generally are more common, well, not, I wouldn't say more commonly used, but are used generally in place of. Because I know that FNA, or fine needle aspiration, is not something that's used very commonly these days, because there are other procedures that generally are used more commonly. And what would those entail?
So the options, if you're needing to get a biopsy, either a surgical excision of the mass, where a pathologist could examine the tissue in its entirety under a microscope. The downside to a surgical incision is that it, of course, requires surgery, and it's a much larger piece of tissue that's removed all at once. The other types of biopsy, there's what's called a needle core biopsy, where they actually use a very thick needle to go in and collect a piece of tissue. Whereas fine needle aspiration uses such a thin needle that patients don't have to have generally any anesthesia. They can come in and actually even drive and go back to work after the procedure.
So as opposed to these more invasive procedures where I would have to generally go to a hospital, have to check into the hospital, generally have to, depending upon what was being sampled, I'd have to change into a gown, and I'd have to be on a table, and I'd have to go into radiology, and it might be an entire day of actually being at the hospital, right, and maybe even sometimes even longer than that. How long does an FNA take? What if let's say I'm a patient and I mention to my physician, if I see a mass like in my breast or in my neck or in my arm, and the doctor says, oh, we need to biopsy that, and I say, well, what about an FNA? How long does an FNA take? Generally, what are the risks involved with it, and is there any downtime? Would I have to worry about missing time for work?
Right, so an FNA, there's very little risk involved. The only risks are bleeding, but it's a very small needle. It's no more significant of a risk than a general blood draw like you would get at your doctor's office. And then a very small risk of infection, but we sterilize it before the procedure, so that's also a very minimal risk. Compared to other procedures, patients, when they walk into our clinic, it takes them really just a couple minutes to fill out some registration paperwork. They're immediately taken back for the procedure, and then the actual procedure itself only takes a couple seconds that the needle is actually into the patient. But I scan it with ultrasound first, and I use ultrasound to guide the needle into the mass to collect the sample. The entire time that the patient's in our office ends up being about an hour, and that includes the entire time that it takes for me to examine the patient, talk to them, collect a sample using ultrasound guidance, examine it preliminarily under the microscope to check specimen adequacy, and then usually I even come back and discuss the preliminary findings with the patient.
So this is something not only that I could get in fairly rapid fashion, but I would also get the results back extremely fast, so I wouldn't necessarily have to worry about it or stress about it for numerous or several days, waiting for a biopsy result.
Correct, yeah. In most cases, we're able to get the results back within 24 hours, sometimes even the same day. Some unusual cases require some additional studies that usually take 1 to 2 days, but in general, from the time that you've seen me, within a day or two, you'll have a result. And like I said, preliminarily, I usually discuss the results with my patients. So especially if it's something that's benign or even malignant, I can go ahead and have a discussion with a patient to let them know preliminarily where we're leading with the diagnosis.
So it would be, so as opposed to having to wait and agonize for days, I would generally know fairly rapidly, and then I could go ahead and continue. We could develop a plan or talk with my physician and be able to move forward and not necessarily have to wait even longer before I was able to get additional, to know what sort of treatment or additional treatment, if any, were needed for me.
Yeah, that's correct. And actually, in fact, we can usually get patients in within the same week, sometimes even same day, depending on the patient's circumstances and their availability as well. So as opposed to getting it done in a hospital where it may take sometimes even several weeks to get everything scheduled and set up in the hospital, we can get the patient scheduled much faster. And since I'm the pathologist also interpreting the biopsy, the results are much faster as well.
So if I'm a patient with a breast mass and I want an FNA on it, would I come directly to you, or would I need to do something else first?
So generally you would go to your primary care physician or another provider that's detected the mass wherever it is on your body, whether it's a head and neck mass, a salivary gland mass, or a thyroid mass that was seen on ultrasound incidentally. And usually those providers will have a discussion with you and discuss the different types of options for obtaining a biopsy, and then they would refer the patient to me.
So is this something that if I want to have done, I could address this with my physician, and the physician then could tell me that this would be a way possibly that I could have this done?
That's correct, and most physicians are aware of this being a technique to obtain the tissue. It's generally, like I said, one of the least invasive methods to obtain the tissue. So rather than going straight to removal, this could help determine, even if the tissue needs to be removed, it may be able to be something that continue to be watched either with ultrasound or just clinically, just to see if it changes or goes away over time.
Well, you mentioned the different areas that can possibly that can utilize FNA. You mentioned the head and neck. You mentioned breast. What about masses anywhere else on the body? Let's say I have something on my lower leg. Are there any areas of the body that, if it's a mass that generally can be detected by ultrasound or by feeling it, are there any areas that could not be approached?
Not really. I mean, pretty much anything that's a mass or a lump that a patient can feel or a clinician can feel is a potential target for a fine needle aspiration, as long as it's a discrete mass and not just a muscle swelling or something like that.
So when you say discrete mass, you're saying it's actually not something like a swollen muscle. It actually is something you can actually feel and has edges and...
Correct. And occasionally a patient will be sent for consultation to my clinic, and by ultrasound examination I can sometimes tell that a mass is not a separate mass from the muscle and may in fact be damaged muscle or damaged soft tissue that wouldn't need a biopsy, and that's something we can take at that time.
So you mentioned another way. You talk about core needle versus fine needle.
Right.
What is the difference in the size between those two tools?
So the needle that I use is a 27 gauge needle in most cases, sometimes a 25 gauge needle, which is a very, very thin needle that actually would fit several of them within inside the bore of a core needle. So a core needle is a much thicker needle, and generally it would require more anesthesia to insert the needle, as well as incision with a surgical scalpel before the needle is inserted.
Now, but intrinsically the size of this needle is about the same size as one you would administer anesthesia with. So as opposed to having two needles inserted in you, you could actually just go with one, correct?
Yeah, and in fact it may even be smaller than the needle that's used for most anesthesias. The procedure that I use, I don't even use injectable lidocaine. The needle that I would use for lidocaine actually sometimes is more painful than the needle that I use for the biopsy. So we use a topical lidocaine cream and a cold spray before we put each needle in, and that helps pretty well with patient tolerance, and patients do very well with this.
So as opposed to going to a hospital, getting maybe multiple needles put in, and then having another needle put in, I could just go into your office and have just one.
Correct, and it depends on the case. Some cases require a few different needle sticks just to make sure that I have enough tissue to work up with different studies. But in comparison to having a large core biopsy and the surgical or scalpel incision to insert that core needle, oftentimes the fine needle aspiration may give a diagnosis that would be something that a doctor could manage for the patient.
So, as a patient, let's say that I've addressed this with, the physician finds a mass, and I've addressed with them, and I'd say, well, I would like to do an FNA or fine needle aspirate. Is this something that my insurance would pay for?
Correct. Yeah, we're really in network with all insurance companies. We even have self-pay rates for some patients that are uninsured. And we work with all patients to ensure that they're able to get the care that they need.
So this is, and because you're such, and how many people actually work in your practice?
So really just two. There's just me and my nurse that she handles the front office.
And you're related to your nurse somehow?
Yeah, she's actually my wife. So yes, my wife is my nurse. She was trained as an RN before, and she handles all of our administrative stuff as well as time in the patient. And patients are actually oftentimes spend more time with the nurse in the room while I'm examining the tissue under the microscope.
So this is truly a very personal experience. This is not something where I'm seeing a bunch of people and being passed from person to person, hand to hand. I'm actually going in and seeing, your wife who is the nurse and then you who is the physician.
That's correct. And actually we schedule all of our patients about 2 hours apart, so you're all actually the only patient in the waiting room at any time. We bring you back quickly, and we spend as long as we need to discuss any issues that you have.
So a truly personal approach with a small needle, which I can get results with fairly rapidly. Why isn't it this is not more widely used?
So it's actually very frequently used in hospitals, but it's frequently performed by a radiologist, which has its benefits and limitations. The training that I received as a cytopathologist in performing ultrasound-guided FNAs enables me to evaluate the tissue while the patient's still in the office to ensure that it's an adequate sample, which would potentially prevent the need to rebiopsy the patient at a later time.
So you not only do the procedure, but you actually interpret the results, and you do all of that in one fell swoop at the office.
That's correct, and it's all within a matter of minutes while the patient's there.
Well, hard to see a downside to that. Any possible downsides? I mean, is there occasionally something that we should be worried about? Any potential complications or anything of that sort that I should be worried about as a patient?
Very little. I explained to all of my patients the potential risks, which, like I mentioned before, is a very small risk of bleeding. But like I've said, the needle is so much smaller than what they use to draw blood when you go to the doctor's office. It's no more of a risk. You may see a bruise a few days after the procedure, but other than that, it's very well tolerated.
Well, sounds like a wonderful procedure. Dr. Snyder, can you give us some information about where you're located in your practice, and if I wanted to contact you, or maybe as a physician, I wanted to contact you and get additional information about getting an FNA biopsy?
Sure, yeah, we're located in West Knoxville, close to where Pellissippi Parkway and Kingston Pike intersect, behind the Calhoun's building. We're located off Fox Road, and the best way to get in contact with us is probably our website, knoxvillefna.com. That's for fine needle aspiration. We have all of our contact information there, and even if a patient wants to contact us to learn more about the procedure, either me or my nurse are happy to talk to them about the procedure and help them have a discussion with their provider to determine if this procedure might be right for them.
Is there any additional information on the website that could give us, that maybe give us more information about this as well?
There is. It actually explains the basics of the procedure, and I've also got a frequently asked questions sheet that explains most common questions and a lot of the things that we've discussed today, but we usually give it to all of our patients when they're at the office, and also some of our providers that we receive patients from, we give that form to them as well so that they can provide it to their patients before they send them.
Most excellent. Well, that certainly gives us a lot of good information about another approach that we can use that will give us a faster, and strikes me as a lot easier, answer to something that could potentially be very worrisome for a patient.
Sure.
So, and with that, that concludes this episode of Doc Talks. Doc Talks is a podcast that is produced by the Knoxville Academy of Medicine and features its members providing information to patients about topics of interest to them. I'm Dr. Rob Page, and thank you so much for joining me here today, and thank you, Daniel, for being here with me today. So, Dr. Snyder, have a great day.
This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.